once again, it's always a privilege to be involved with you all, and congratulations on putting the program on another year. For those of you who were on last year, you'll recall that I did talk about exercise and cancer. Some of the slides you're going to see this year are going to be the same, but I've got some new slides for you. So hopefully it'll still be an entertaining talk. Slides that I'm showing, some of them are mine. The others are from Dr. Catherine Schmitz, who's a professor of hematology and oncology at the University of Pittsburgh School of Medicine. Katie is one of the top 2 researchers, certainly in the United States, if not worldwide. And then Dr. Karen Wonders is a professor at Wright State in Dayton, Ohio, and also the founder of Maple Tree Cancer Alliance that I'm involved with as the chief medical officer. So let's talk about what the situation is worldwide. Worldwide is estimated in 2020 that 18.1 million individuals were diagnosed with cancer, and a little over 9.5 million died from the disease. The World Health Organization states that cancer is the leading cause of death worldwide, accounting for nearly 10 million deaths in 2020, about 1 in every 6. Not surprisingly, the most common cancers worldwide are breast, lung, colon, rectum, and prostate. And here in the United States, these are big numbers, guys. The lifetime risk of developing cancer is about 40% in men, of which probably the biggest number is prostate. The older we get, the higher our incidence of prostate cancer goes. And it's almost the same number in women, around 38%. And one of the things that's a whole nother talk is all about lifestyle and diet and things of that sort. And I'll emphasize a little bit of that later on. But these are contributing factors. The more industrialized we've become worldwide, the more industrialized that Asia has become in places like that, the incidence of cancer is clearly going up. Excuse me. In 2018, around 1.7 million individuals were diagnosed cancer in the US. The direct and indirect annual costs of cancer care in our country is almost $160 billion. And billions of additional dollars are lost to disability, lost work, lost household productivity, etc. So needless to say, the burden of cancer is really big worldwide. Here's a new slide for you about cancer prevention. This comes from my not-for-profit in Dayton, Ohio, Maple Tree Cancer Alliance. And this next slide will sort of highlight that. As I said a moment ago, in the US, between 1.7 and 1.8 million people diagnosed with cancer each year, but of these, only about 5, perhaps 10% are attributable to the genetic defects that we know today. And I really want to emphasize the genetic defects we know today because that list is always growing. We do know that male breast cancer can be from a BRCA gene defect and some others. I remember, frankly, when BRCA genes were first discovered, what we know today is years later, that was just the tip of the iceberg. And the more and more we get into the molecular biology of cancers, the more we're going to find these genetic defects. So at least what we know today, it's around 5 to 10%. Therefore, the remaining 90 to 95% of cancers probably have their roots in environmental and lifestyle causes. And what are these lifestyle causes that you and I, our friends and neighbors, our family members can modify? And the 3 biggies are diet, our sugar-based diet in Western Europe, the US, Canada, Australia, New Zealand, etc., and the more westernized Asia has become. Our physical inactivity, I just cannot emphasize this enough. As I shared with you last year, I'm a newbie to the world of exercise oncology, and I have an email that I put out once or twice a week now to about 150 people in 17 countries on the latest publications that I can find on exercise/cancer. And more, we see that physical activity is a big contributor, as well as the amount of obesity that we increasingly have in Western Europe, US, Canada, Australia, New Zealand, more of Asia, more worldwide. These other ones we've known about for a long time: sun exposure with malignant melanoma, cigarette smoking leading to lung cancer, as well as heart disease, too much alcohol consumption, HPV infections, and other environmental pollutants, more of which are to be determined. Here's an interesting new slide for this year's talk, and this has to do with the top 10 leading causes of death in the United States. This is from data from 2017. And if you look at the first two, heart disease and cancer, this makes up about 45% of all deaths are just in these two categories right here. And then we know that diet and lack of exercise contribute to stroke and cardiovascular disease, clearly to diabetes. And I have thought for some time, and I think the data is becoming clearer, that Alzheimer's is going to be, if you'll excuse the expression in quotes, probably the diabetes of the brain. In other words, related more and more to our westernized diet. So these are big numbers that are related to lifestyle. The rest of the numbers, notice how small they are. Unintentional injuries, only about 6%. Chronic lower respiratory tract disease, a little under 6%. Influenza, pneumonia, as much as we were scared by the pandemic, really only make up about 2%. That number went up some, obviously, during the pandemic. Kidney disease, often in this country related to diabetes, less than 2%. And suicide, which is a big public health issue, over 47,000 people. So I've highlighted these numbers because these can be modified by us if we can just start concentrating more and more to our focus on lifestyle issues. What is exercise oncology? I just got back from the American College of Surgeons meeting in Boston and walked up to a bunch of my surgical colleagues and said, "Hey, what's exercise oncology?" And I get back a big blank stare. Well, here's a good definition of it. Let's think of it as adjunctive therapeutic approach to cancer patients. Hopefully everyone understands the word adjunctive means in addition to. So when we talk about therapeutic approaches in cancer, the classic things are surgery, chemotherapy, radiation therapy, anti-hormonal therapy, etc. So that exercise would be an adjunct to these approaches. And the data from this has been emerging from several thousand, over 25, as you'll see now, over 2,600 prospective, often randomized clinical trials conducted over the last 20 years. What's resulted from these are moderate to strong evidence of the positive impact of exercise on cancer patients' fatigue, anxiety, depression, particularly quality of life, certainly physical function, sleep, bone health, and breast cancer-related lymphedema. It's really important to point out that organized exercise oncology programs are evidence-based. We need to continue to emphasize that all of the practice of medicine should be evidence-based. And that's certainly the case here with exercise oncology. So evidence-based program with supervised, individualized exercise training done on site, and certainly because of the pandemic now more and more virtually. My goal, my personal goal, and sort of the back nine of my career, if you will, is to make exercise oncology programs an international standard of adjunctive care, as it already is in Australia. I shared with everybody last year that in 2018, 5 years ago, the Australian ASCO made exercise a standard of adjunctive care. And the American College of Sports Medicine, a lot of my colleagues say, GJ, why do we know more about all this exercise oncology business? Well, a lot of the research, in fact, 98%, has been done by PhD researchers, many of whom are members of the American College of Sports Medicine. And they've actually trademarked the name Exercise is Medicine. And Dr. Katie Schmitz has been leading the charge on this. The other thing that we talk about is food is medicine. So we need to think more and more about our diet and food as medicine, as well as exercise as medicine. Here's a review of the randomized RCTs, randomized clinical trials. There are two types of randomized clinical trials. These are organized exercise-based programs or physical activities, where like playing golf, jogging regularly, playing soccer or whatever. Look at the growth for over the last 20 plus years of the number of clinical trials that have gone on. This is from PubMed. This was one of the last slides I showed last year. Now through 2023, we're up over 2,600 clinical trials. This is really hard evidence, everybody. So let's go through those that are organized and the data on breast cancer. And by the way, I was with Katie Schmitz in Boston at the Commission on Cancer meeting, and I said, Katie, I've got a talk coming up to the male breast cancer group. Do we have a specific clinical trial when it comes to men with breast cancer and exercise? She said, I'm sorry, Jay, we don't. Interestingly, of all the clinical trials done in the world of exercise oncology, probably in the neighborhood of over 70% have actually been done in the world of breast cancer, but not specifically is there one on male breast cancer. So this is looking at post-diagnosis physical activity and breast cancer survival. So how do we define this? Somebody's newly diagnosed with breast cancer, they go through their treatment, and post-diagnosis get involved in active exercise activities. Here's an analysis of 12 different studies that basically show over a 31% improved survival by being involved in exercise activity regularly. What about physical activity, its impact on recurrence? Well, here's a summary of 5 studies, 22% in lower recurrence rate by being involved in regular ongoing physical activity. And I'll give you some definitions of this in another slide. And then what about post-diagnosis? And I really want to emphasize this on ACM, all-cause mortality. This is actually the biggest impact, looking at a 41% lowering of all-cause mortality. And I'm going to be talking about this again in another slide coming up. In other words, dying from causes other than cancer, the leading of which, of course, is heart disease, stroke, vascular disease, etc. So you can see these trials date back nearly 20 years to 2005. As I said a minute ago, the activity or the data is overwhelming. So summarizing the 3 slides I just showed you, summary of evidence of breast cancer survivorship, physical activity, cancer-specific mortality. In other words, dying from breast cancer if you're regularly involved. And yes, I know this depends on original stage, cell type, markers, and a variety of things, but in the collective studies, a 31% reduced risk of cancer, breast cancer-specific mortality by exercising regularly. Recurrence rates lowered 22%, but as I said a minute ago, here's the big number, ACM, all-cause mortality at 41%. Here's one of the most important studies that just came out a couple of months ago in August of this year in the Journal of Clinical Oncology. For medical oncologists in the world of cancer, the Journal of Clinical Oncology is one of the most important journals. This is from the group at Sloan Memorial. Lee Jones, right here, Dr. Lee Jones, another PhD. As I said a minute ago, probably he and Katie Schmitz are the two leading researchers in the United States when it comes to exercise oncology. Lee actually runs a department in Memorial Sloan Kettering called Exercise Oncology. The name of this paper is Pan Cancer Analysis. Whoops. Come on, go on up there. Get up there, kiddo, so I can see the title. All right. Post-cancer analysis, or cancer analysis of post-diagnosis exercise, on exercise and mortality. Here's a summary of that paper. The Memorial Sloan Kettering, Lee Jones. This is an analysis of 11,480 patients enrolled in a prospective prostate, lung, colorectal, and ovarian cancer screening trial. I'm sorry that breast cancer is not included in this, but when you're tracking nearly 11,500 patients for 16 years, the numbers are real. So what they did was to compare people who are in exercise programs that were consistent with US national or international guidelines. In other words, there are published guidelines of what an exercise program should entail. And they compared the group of those in those exercise programs versus those that weren't. Exercise consistent with guidelines was associated with a 25% reduced risk of all-cause mortality compared to non-exercise. Now remember, this is prostate, lung, colorectal, and ovarian cancer. Then in this big report, and I didn't put up a separate slide on this, the cause specific, meaning the individual cancer impact of exercise, differed as a function of the original cancer site. In other words, the impact of cancer might be different on cancer-specific mortality in prostate cancer versus lung versus colorectal and ovarian. In the overall aggregate literature, the two biggest impacts are on breast and colorectal, and they vary depending on these other cancers. So this is a huge report, big numbers. I think the impact of cancer is really quite clear. As I shared with you last year, I'm involved with Maple Street Cancer Alliance, a 501c3 based out of Dayton, Ohio. We're well over 60 hospitals in the US, 5 in Brazil, and we export training programs to physical therapy departments and physiatrists overseas. Our biggest one right now is in mainland China, another new one in Australia, and several others. Think of what these exercise oncology programs are. If any of you know anything about cardiac rehab, what you're going to notice here is a strong similarity with cardiac rehab. In other words, there's an increasing emphasis now in prehab. Somebody is brand new diagnosed, and we want to be able to start them in activity and exercise even before any of the treatments start. A good example in breast cancer would be the triple negatives, would be the HER2 new positives who we know are going to get neoadjuvant chemotherapy. Also in pancreatic cancers, we're doing more and more neoadjuvant chemotherapy. Same is true in rectal cancers. Phase 1 then is those currently involved in chemotherapy or radiation therapy. These are 12-week phases. Phase 2 is those completed their chemotherapy and radiation therapy or only receive surgery and or hormonal therapy. And phase 3 is long-term survivorship. Another thing to remember about exercise oncology, there's sort of two phases to exercise oncology. The first phase is the newly diagnosed patient and in active treatment. Prehab, active treatment, immediately post-treatment. But the bigger long-term phase is really going to be phase 3, which can be done out in the fitness industry. And ever since the pandemic, the fitness industry really took it in the shorts as far as losing business and shutting down. So there's a stronger area of interest now in getting involved in chronic diseases and training their trainers. And we're starting a program with smart health clubs in the United States to train trainers in the fitness industry to work with long-term surviving patients. So what are the exercise guidelines during active treatment? And remember here, the goal during active treatment is to improve symptoms and side effects and help keep people in treatment. A minimum of 3 to 5 times a week of aerobic exercise for 30 minutes per session. What we're not talking about is training for the New York Marathon. We're talking about walking. We're talking about walking briskly. And if you can get up to 5 times a week, think about it. That's 30 minutes. Most of us can walk close to 20-minute miles. I do 2 to 3 miles every morning, right around 19 minutes a mile. That's a really brisk walk for well over 30 minutes. So if you can just get moving and do that 3 to 5 times a week, and then twice a week, add some strengthening exercises such as resistance bands and what have you, the impact during active treatment is really incredible. At Mapletree, we have a cloud-based data system. This number of patients is now over 12,000. Here's of what I just described to you. Here's the impact on the physical and psychological impact on cancer patients at Mapletree. These are all cancer patients, breast and others. Here's one of the biggest: increased quality of life, nearly 60%, increasing cardiovascular endurance, about 15%, maintaining or increasing muscular endurance, 18%. Flexibility is a big one. You know, patients were told historically, especially during chemotherapy, I know you feel like hell, just go home and rest. Okay, for the first day or so, great. But let's get moving after you get through each cycle. Feeling more positive. This is huge. Take a look at this. Quality of life, nearly 60%. Feeling more positive, a little over 75%. And here's another big one, nearly 60%. Feelings of support. What happens in these programs is the patients bond with their exercise specialists. And as the programs now go back more to groups, they then bond with the group. So the impact during active treatment is really quite real. I'm about to wrap up here. All the big groups, American Society of Clinical Oncology, ASCO, has a guideline out last year that says if you're in active treatment, you should be referred. Let me repeat that. If you're in active treatment, particularly for cure, you should be referred for an exercise program for aerobic exercise and resistance training. The National Comprehensive Cancer Network has wonderful guidelines in the area of survivorship. They talk about 150 minutes a week of aerobic exercise and 3 days a week of resistance training and resistance workouts. What we're trying to do with NCCN is to get them to move that same exact work they've already done into active treatment. Right now, they're silent on active treatment. But these two, that's active treatment, survivorship. American Cancer Society has a strong statement. Center of Disease Control, National Cancer Institute, all these other groups as well. National Accreditation Program for Breast Centers, NAPBC, is the gold standard for comprehensive breast centers that involve surgeons, medical oncologists, radiation oncologists. Their new standards have been revised and are taking effect this coming January. We have gotten included in the new standards pre-surgical assessments, post-surgical referrals, particularly referrals during chemotherapy and survivorship. This is all brand new in these standards. This obviously 98, 99% of what any PBC standards do are women. But while I was involved at our NAPBC center, I obviously took care of men as well as women, so it will involve men. What are the models for doing this as I wrap up? We've got about 8 or 9 minutes to go here. There are sort of three approaches. There can be programs that involve practice models such as groups. And I'll give an example of that, a consultation model and a one-on-one model. A good example of groups are Live Strong at YMCAs, dragon boat racing teams. That's been particularly true on the West Coast. Fit steps, there we go, for life. There are obviously many other examples. Hopefully these groups have at the group that are specifically for cancer patients and survivors, hopefully they've got professionals with specialty training in exercise oncology, excuse me, involved with the group. Another model is what's called a consultative model, where there's a consultant at a cancer center who can do assessments, who can then create an exercise prescription, and can then offer guidance and then refer patients either to physical medicine departments, physical medicine or physical therapists, or out to community appropriate resources, or even to home virtual exercises. And this is what's called the consultative model. And these can be embedded in cancer programs. And then what I'm involved with at Maple Tree, which is more of a one-on-one model with the things that I've shown you. And a lot of our programs are all done virtually. So there's no question about the effectiveness of programs. One of the things that I would caution you that does not work is handing a patient a brochure and saying, Mr. or Mrs. Jones, do this. However, what's interesting, there's some trials going on now where they ask the couple and give a brochure to a couple and ask the spouse to be involved with the patient to make sure they do it, and there's higher compliance with that as well. And our goal at the American College of Sports Medicine and Maple Tree and Jay Harness personally is to make us, to see us make this a standard of adjunctive care in the United States. And my last slide then is from Katie Schmidt's 2 books. This will be the gold standard for academic centers, the whole textbook, Exercise Oncology. Then here's the text, our book, I should say, Moving Through Cancer, that Katie authored, designed for patients and also designed for caregivers. Brett, I'm back, and we've got about 5 minutes if anybody's got any questions, okay? And Brett, you're on mute.
Yeah, I got you. One question, since I know I was told about, back in 2010 about exercise, was still good for it, but I had to be very cautious, like, being around large groups while going through treatment because of low white blood cell counts.
Yep.
Is this something that is offered like in the hospital and more of a clean environment, not large, like just, manufactured gym? Is that how it's done? It's recommended, or?
Sure. So the model is all over the place. First of all, because of the pandemic, more and more of these are being done virtually. In fact, there's a recent clinical trial out that compared virtual programs with on-site programs. And believe it or not, people have things at home that they can use, cans of beans and things to do bicep curls with, or resistance bands, or doing squats at home or whatever. And this was a randomized trial. In fact, Maple Tree put it out, and they both were found to be equally effective. You're right. During active therapy, when your white count and platelet counts are down low or whatever, obviously you're going to wear a mask. It would depend on the cancer center that you're involved with. The physical therapy department, usually the physical therapist can wear masks, the patients can wear masks, and there can be in clean areas. During active treatment, you're going to probably want to avoid the class setting if somebody's doing it in the class setting, or just getting out and moving on your own, Brett. And I love this clinical trial I found recently where it's couples. The spouse of the patient is urged to work with the patient to get them out of the chair, outdoors, moving, stretching, doing squats, etc., etc. As we well know, if we hand a brochure to somebody, odds are it's going to end up in the circular file, and somebody's not going to do it. Any other questions that anybody's got? It's just such a treat to always be with you guys. Peggy, I see
Yeah, I
you
got a
got your
question
hand
here.
up there, Peggy.
If could you send us an email that I could share with the brothers so they can get on your email list?
Yes, ma'am. I absolutely will.
And that way we'll share it out with everybody. And
Well,
they
you
can
know,
sign up.
here's what. Yes, I would be happy. I have lay people on the list. As I said, I've got over 150 people on the list right now from 17 countries. So I do a Google alert every day that says exercise/cancer. I'm very public about my email. It's the letter J. It's the letter K. It's then harness, like you put on a horse, HARNESS @gmail.com. If you send me your name, and obviously I've got your email, and anything else about you that I would be happy to add people onto the list. You bet, Peg.
Wonderful. Yeah. And just if you shoot me that, then I'll post it and then they can send back and sign up.
All right. Sounds great. I'd be happy
That's
to do
wonderful. We can't thank you enough. Are there any other questions for Dr. Harness? Or if not, we appreciate all your time, darling.
that.
Thank you
Oh,
again.
Peggy, it's always great to be with you and Brett.